My dear friends, today I am going to touch upon an important subject, an important area of critical illness in the ICU that is often baffling and keeps us baffled till we are able to reach a diagnosis. And that is delirium, a very common condition, but often difficult to treat and which has very important consequences both in the early and the late stage of the disease. Let us start with this case. A 40-year-old male, a victim of road traffic accident, was admitted with fractured ribs and flail chest for 1 day. Patient undergoes thoracotomy followed by rib fixation and is on elective mechanical ventilation after the surgery. On the second day of the post-operative period, the patient develops irritability, agitation, and clouding of consciousness. Alongside, there is an increased requirements of sedatives and analgesics to calm down the patient. Otherwise, the patient is hemodynamically stable. The GCS is E4, VT, and M6. Patient is on volume control assist and generating reasonably adequate tidal volume within the normal range with a normal respiratory rate. The investigations of the blood, the CBC is normal. The chest X-ray shows mild opacity in the lung bases, and the ABG shows only mild respiratory alkalosis. So how will you rule out delirium in this patient? It is very important to clearly have a view or the understanding of delirium in before diagnosing delirium. The term which was often used in earlier days to tell about delirium or mimic some conditions akin to delirium was ICU psychosis. Now, is delirium same as ICU psychosis? If you go by the DSM-5 criteria, delirium is an acute change in attention and awareness that develops over a relatively short time and is associated with additional cognitive deficits. And this additional cognitive deficits can be memory deficit, can be disorientation or perceptual disturbances, or their combination, more than one of them. It is found to occur in a variety of patients in hospitalized patients the range is very wide between 20 to 70% if we see, and therefore it definitely it imposes the threat in certain patients who have risk factors for and who develop those precipitating causes to develop this delirium. The term ICU psychosis, which was earlier used to describe a state akin to delirium, is not exactly so. It is an outdated misnomer, and it was previously used to refer the hyperactive delirium in an ICU setting. Now, there are other types of delirium, the hyperactive delirium and the mixed delirium. So it is only one particular type of delirium that was termed as ICU psychosis when the other subtypes were not recognized. And the possible causes of delirium can be very wide. They may range from intoxication and withdrawal states to important neurological insults like stroke and meningitis. And it is very important to distinguish the physiological states and the pathological states because the identification of the cause or the treatment of the root cause of the problem is the primary treatment for delirium. So prevention, identification, and management all have important consequences in the outcome of patients, both in the hospital and after their discharge from the hospital. Now, how do you identify two reliable tools which have been found useful in ICU setting? One is the CAM ICU and the other is the ICDS. So in the CAM ICU, it provides two steps, and the consciousness is evaluated through a standard in the first step, through a standardized scale, that is the Richmond Agitation sedation scale, which is a 10-point scale ranging from +4 to -5, where RASS of 0 indicates calm and alert patients, and the RASS of -4 and -5 are indicative of coma, so they cannot be assessed for delirium. So for all other stages, that is beginning from +4 to -3, these individuals are evaluated through the second step. And in the second step, they assess 4 characteristics of delirium, which you can see on your screen. The feature 1 is altered mental status or fluctuating course. And if this is absent, so it can be CAM ICU negative, then it is no delirium. If it is yes, you look for the second feature, which is inattention. For inattention, you have to suppose this is the typical example which is cited in the textbooks, that squeeze my hand on the letter A. So as you pronounce save heart, SAVEAH, so every time the word A is uttered, the patient is expected to squeeze the hand. This can be accompanied with other picture cards where the patient sees a particular picture and is asked to squeeze the hand when seeing an apple or an orange or a bird. So if there are only 0 to 2 errors, then that is also CAM ICU negative or no delirium. If there are more than 2 errors, then we look for the third feature, that is the altered level of consciousness. If the answer is yes, then it is CAM ICU positive or delirium is present. If the answer is no, then you look for the fourth feature, that is disorganized thinking. So disorganized thinking, if the patient is intubated, patient will not be able to talk, but the patient can be instructed to tell the answer with his fingers by using single finger or 2 fingers, like will a stone float on water? 1 for yes and 2 for no. Are there fish in the sea? So if the patient commits 0 on 1 error, the patient is CAM ICU negative, that is no delirium. If the errors more than 1, then the CAM ICU is positive or delirium is present. Now, 3 out of 4 features are required for the diagnosis of delirium. That is from feature 1 to feature 4. So 3 features are required. Now, if you see that this is the CAM ICU, this we will understand that it is an algorithm which is easy to perform and can be used by personnel with minimal additional training. So that way, its implementation in the ICU can be easier in comparison to more complex tools. The other tool which is also useful is the intensive care delirium screening checklist list, or the ICDSC. Now, this in contrary to the two-step tool of CAM ICU and the second step with the 4 features, this has a component of 8 components, and score 1 point is even given to each component present. Now, there is important that the level of consciousness is first evaluated on a 5-point scale, that is from A to E, which ranges from unresponsiveness in A to exaggerated response in E. Patients who are scored in the categories of A, that is no response, or B, that is response to intense or repeated stimulation, are not assessed any further. The other patients, that is the C, D, and E, they are checked for the information collected during the previous 24 hours. Information means information about this 8 components. So this 8 items are investigated, that is whether they are present or absent. So that gives a score of 0 to 8, and a score of more than 3 is considered diagnostic of delirium. So if you compare the CAM ICU with others, the CAM ICU, of course, is the commonest tool that is employed worldwide. And its content, as I said, there are 4 features depending upon the step 1. And a delirium score is positive. Its features 1 and 2 are present, plus either feature 3 or 4. That is more than 3. In ICDSC, there are 8 items, dichotomized items, presence or absence for a possible score of 0 to 8. And the delirium score is confirmed when it is equal to or more than 4. In addition of these two, there are certain other scores like the new desk, which has 5 items, and an item of more than one is considered to be uh, positive for delirium, the DDS and CTD. So these are also other scores which are considered to be useful. The new desk is considered as useful for the nursing delirium screening scale, and it has been validated in a large part of the Europe and found to be useful in the nurses. CTD is, and that is the cognitive test for delirium, and DDS, which is the delirium detection score, has found limited utility in terms of their complexities, but still their specificity is high, even if not the sensitivity. But in addition to these tools for ICU detection, a careful clinical assessment must be performed because the cause responsible for delirium should be identified and treated. So if the cause is missed, then even identification of delirium will not lead to its adequate treatment. Now, if you compare this to CAM ICU 7, which is the most recent CAM ICU version available, versus the ICDS code, and we all know that a patient is considered to screen positive for delirium if the CAM ICU score is greater than equal to 3, or the ICDS score is greater than equal to 4. You can find a lot of subsyndromal candidates can be identified in the pink zone, and this is wider in case of ICDSC because the range is between 1 to 3, whereas its range is between 1 to 2 in CAM ICU 7. But within delirium, the CAM ICU 7 is able to identify the severe delirium from mild to moderate delirium based on the scoring of 3 to 5 and 6 to 7 for mild to moderate versus severe, which goes undetected in the ICDSC because here we get the same scoring level of 4 to 8 for the entire range of delirium. So these are the two differentiating points in which one can separate these two scores, or one can identify the advantage of one over another. Now, what can the differential diagnosis? Certainly, delirium also needs to ascertain the differential diagnosis that are importantly eliminated by exclusion before confirming delirium, and this can be neurocognitive disorders, psychotic disorders such as brief psychotic disorders, schizophrenia, schizophreniform disorders, mood disorders like bipolar and depressive episodes, acute stress disorder, and malingering or factitious disorder. You have to remember that delirium is a diagnosis of exclusion and it requires accurate clinical testing and observation. So greater the accuracy, the greater are the chances of correct diagnosis of delirium. So as I mentioned before, that there are certain subtypes of delirium. The acute psychosis was the term which was used in earlier days to refer to hyperactive delirium. Now, this hyperactive delirium is more commonly identified form of delirium outside the ICU. Whereas in the ICU, we get the mixed type of delirium, that is hyperactive fluctuating with hypoactive delirium. This is the commonest. And second is the hypoactive delirium. So mixed is around half of the cases is because of mixed delirium, and 1/4 or little more than that is because of hypoactive delirium, and even lesser is the hyperactive delirium. And this is important because hypoactive delirium is often underrated, and because it is underrated, missed, and not adequately treated, it is also associated with worse prognosis in comparison to the other two. It is important to remember that any new onset psychotic symptoms in older adult patients, particularly who have undergone an intervention or surgery or under procedure under anesthesia, they are unlikely to be a primary mental illness if it is new onset. So one should rule out some delirium, of course, and the subtype of delirium. So what are the risk factors? There are certain predisposing factors and certain precipitating factors. Predisposing factors include advanced age, baseline cognitive impairment, increased comorbid disease frailty, drug and alcohol abuse, and higher grades or higher severity of the illness. The precipitating factors include metabolic disturbances in the form of various encephalopathies, hypotension, sepsis, poor pain control, mechanical ventilation, sleep disturbances, use of drugs like benzodiazepines, opioids, deep versus light sedation, anticholinergic steroids, surgeries particularly involving abdomen, cardiac, hip, etc. Now, there is a mnemonic bundle which is called Delirium. It is using the same alphabets that lies in the spelling, which was proposed by one center for assessing the main causes of delirium. D stands for the drugs, which I have mentioned just now. E stands for eyes, ears, and other sensory deficits. L stands for low oxygen states. I stands for infection. R for retention of either urine or stool. I for again for ictal state. U for underhydration or undernutrition, and M for the metabolic causes. So this mnemonic may be useful in certain cases. Again, if you look into the predisposing factors and the precipitating causes, you can see that there is low vulnerability among for some of these factors as you move on, like as a precipitating cause, you can see that the major surgery, ICU stay, so there the vulnerability is the high, whereas the urinary tract infection, benzodiazepine use, the vulnerability is less. With consideration to the predisposing factors, a pre-existing dementia, severe comorbidity, they have high vulnerability in terms of predisposing factors, and healthy older person has a low vulnerability in terms of predisposing factors. So this needs to be understood that because it will vary from patient to patient, and one patient may have certain high vulnerability factors in terms of predisposing factors, while low vulnerability in terms of precipitating causes and yet manifest delirium, whereas someone having high vulnerability for precipitating causes and low vulnerability for predisposing factors may not manifest delirium. So it is important to individually label the predisposing causes and the precipitating causes separately and on the basis of their vulnerability. And for that, a complete neurological and physical examination is must, because that will give all possible clues to suggest the cause of delirium. Now, what are the potential mechanisms of delirium? It is important to know because the therapies are guided by the potential causes, and all the pharmacological medications that are used in delirium has their distinct actions on certain areas of brains and are likely to affect certain pathways which can produce some kind of side effects or adverse effects. Many theoretical mechanisms have been proposed, and they range from neurotransmitter dysregulation, like the acetylcholinesterase inhibitors, which reduced cholinergic inhibition, as you can see on the top, to neuronal aging, to oxidative stress, the disturbances in the sleep-wake cycle, among many. And therefore, whenever there is a systemic insult, there is inflammation, endothelial dysfunction. So this all leads to microglial activation, astrocytosis, cytokine release, and that are all possible because of disruption or injury to the blood-brain barrier. And in those particular types, anti-inflammatory agents act by inhibiting this step. The anticholinesterase inhibitors act by reducing cholinergic inhibition. The antipsychotics act on the neurotransmitter alterations and apoptosis. So all of them have varied influences on the causation of delirium. So we have both pharmacological and non-pharmacological strategies for management of ICU delirium. But it is important to consider as foremost that what is the underlying cause. If you are able to detect the underlying cause, we should always try to treat the cause, and the delirium will correct by on its own. Correction of potential electrolyte disturbances, removal of offending pharmacological agents which are responsible for the delirium, maintaining proper sleep-wake cycles. Sleep-wake cycles get disturbed in the ICU for a patient because of alteration in the perception of day, night, etc. So this alteration of the sleep-wake cycle and is responsible. So maintenance of the sleep-wake cycle is important. Management of pain, another very important cause for delirium. Address sensory impairments like hearing, vision, etc. Because if the patient is unable to perceive through these end organs, then there is high likelihood of developing delirium. Encourage family visits and frequent orientation because they have the psychological effect by reducing delirium, and early mobilization no doubt reduces a large extent the incidence of delirium. However, it is accepted that there are no identified therapies, either medications or interventions, that are proven to decrease the duration of delirium. So what are the common pharmacological delirium treatments? You have a lot of typical antipsychotics, atypical antipsychotics, drugs that cause antagonism of presynaptic alpha-2 adrenergic receptors like dexmedetomidine and gives rise to decreased adrenergic signaling. And they have been studied in some of the major trials, the SIDCOM, MENS, Dahlia, SPICE-3, etc. And they have been shown to be useful for speed resolution of delirium and liberation from mechanical ventilation. And there is mixed evidence or beneficial or no effect of incidence and duration in some studies. This is for dexmedetomidine. However, for typical antipsychotics like the haloperidol, the primary target are the D2 dopaminergic receptors, leading to decreased dopaminergic signaling. Their effectiveness, they have no effect on delirium severity, symptom resolution, length of stay, or mortality. And the same has been seen in a lot of good studies like Reduce, Hope ICU, the Mind USA study. Recently, the second portion, the part of the Mind USA study was published, which looked into the long-term effects of patients with ziprasidone and haloperidol. Then atypical antipsychotics is that in Mind USA we have seen. They also have action on the mixed serotonergic, cholinergic, or histaminergic receptors in addition to the D2 receptors. Melatonin, they have agonism at melatonin receptors where they lead to prolonged duration of sleep and fewer nocturnal awakenings, but no major trial has still now proven that. Two RCTs of Ramilton showed lower incidence and duration of delirium when used preventively. And although one of them studied mixed population, that is ward and ICU population, were combined. Ketamine, which is an NMDA receptor antagonist and leads to decreased excitatory signaling, has also effect on multiple monoamine pathways in the signaling pathways, and one RCT has showed decreased delirium with ketamine in cardiac surgery patients on bypass. However, major trials are lacking. So there is debate regarding the utility of antipsychotics and medications like physostigmine, rivastigmine, donepezil, etc. in preventing and decreasing the duration of delirium. But there are certain salient points which one has to remember during pharmacotherapy. One is the cardiotoxicity. Cardiotoxicity, particularly QT prolongation, torsidity, pointis, and hypotension. This has been reported at high doses of haloperidol as well as with other antipsychotics. And caution should be taken when antipsychotics are used with other QT prolonging medications. So whenever there is a risk, either that medication, erythromycin, etc., whichever drug is there, it should be stopped, or this haloperidol or antipsychotic agent should be stopped. Simultaneously, both should not be given. Antipsychotics can also induce EPS-like features mimicking Parkinsonism, dystonic reactions, or akathisia, and they will vary in their severity and onset. So it needs to be seen that if it occurs in a patient, to what extent they are tolerating the symptoms. If they are unable to tolerate, then the offending agent should be stopped. Olanzapine and quetiapine, they are relatively new. They may induce excessive sedation, whereas ziprasidone is more associated with QT prolongation among the newer ones. And benzodiazepines like midazolam and lorazepam are useful in patients with alcohol or sedative withdrawal or for delirium resulting from seizures. So in the ICU setting, although there is no concrete evidence that treatment with haloperidol will reduce the duration of delirium, it is the most commonly adopted treatment in large part of the world, and generally it is safe and has been found to be useful. But pharmacological intervention is not the only intervention that can cure delirium. Various non-pharmacological measures are as important as the pharmacological ones. The first and foremost important is the orientation activities, the oral fluid repletion, early mobilization, vision and hearing aids. If patient is not able to comprehend or understand the spoken words, then such help should be taken. And sleep, pain, and medication. So this should be adequate, because if they are disturbed, then there will be a high risk of delirium. So behavioral strategies always focus on patients' reorientation, and it is useful in cooperative patients with delirium, with occupational therapy, patient and family training, etc. But sometimes it may not be useful, and that time it is a challenging situation. Mobilization, as I have already mentioned, that early ICU mobility can accelerate weaning from mechanical ventilation, reduce the ICU length of stay, and the duration of delirium. The use of restraints should be carefully used only if other interventions fail. And even when they are used, they should be used for the shortest possible time, and they should be focused on deterring a specific behavior that impedes the delivery of care. More importantly is the prevention of delirium. So whenever we come across a high risk patient with some important predisposing factors, so in those patients, it is important to follow this ABCDEF bundle. A stands for assess, prevent, and manage pain. B stands for both SAT and spontaneous and breathing test, and SBT, multidisciplinary coordination of care, faster liberation from mechanical ventilation. C stands for choice of sedation, that is targeted light sedation when sedation is necessary, avoidance of benzodiazepines when they are not required, dexmedetomidine if high delirium risk, and cardiac surgery, etc. D stands for delirium monitoring and management, which is done by routine CAM-ICU or ICDSC assessments, along with non-pharmacological interventions, sleep hygiene, etc. Early mobility and exercise is for E, where physical and occupational therapy are started, and coordinate activity with SAT or periods of sedation, and progresses through a range of motion, sitting, standing, walking, and adjusted daily lives, etc. F stands for family engagement and empowerment, which is one of the important key components, although it comes at the end, but probably in importance, it should stand over others. It stands tall over all others. So reorientation, provision of emotional and verbal support, cognitive stimulation, participation in mobilization, participation in rounds, they are all important. Recently, we have come across also underpin, that is nursing delirium preventive interventions in the ICU. Now, this underpin ICU, which consists of standardized protocols at implementing several modifiable risk factors and interventions, they are mainly focused on cognitive impairment, sleep deprivation, immobility, and visual and hearing impairment. There are some other prediction models also, like prediction model for delirium, that is pre-deliric, and early prediction model for delirium, that is pre-deliric. They have also been proposed, and they maybe have some important role in the prevention of delirium, particularly in high-risk patients. So what is the prognosis? How do the course of the disease gets affected by by the occurrence of delirium. Now, patients with delirium have a more extended hospital stay, a higher 6 month survival is lower than the patients without delirium, but their long-term cognitive impairment is much higher. And even if they survive, they can develop some cognitive deficits. So their quality of life is going to get affected and it may become poor. These patients also acquire more frequent ICU admissions, and therefore they get repeated exposure to a lot of resistant bugs where antibiotics fail to work. Then there is higher incidence of unintentional removal of catheters because they tend to pull out all the lines, etc., from the body, or the endotracheal tube, urinary catheter, etc., and they need to be reinserted, which causes inconvenience to the patient, to the doctor, and as well as it causes a rise in the cost of care. So delirium has severe consequences for patients while they are in the hospital, because in the hospital, the mortality increases, the duration of length of stay in the hospital as well as in the ICU increases. And also after discharge, if they have prolonged cognitive impairment, then also it is important to follow these patients and see the root cause gets treated. So my take-home message would be, symptoms of ICU delirium usually manifest with acute onset and transient fluctuation throughout the day, and they may persist for even days or months. Hypoactive delirium is a severe and most commonly the missed form of delirium in ICU. Prevention of ICU delirium is imperative. Delirium is a diagnosis of exclusion. One cannot say with absolute certainty that someone is having delirium. Soft restraints should be used judiciously and only after trying behavioral and pharmacological interventions, not otherwise. And when verbal and non-verbal behavioral techniques are ineffective or not appropriate, haloperidol can be considered while starting at the lowest clinically effective dose. And of course, QT prolongation is a serious side effect of many antipsychotic medications. So whenever a patient is put on an antipsychotic medications, patient should be followed up for early detection of any complications that may arise. So that's all about ICU delirium. Hope you have liked it. Thank you very much.